Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
All right. Hello, this is Tim Fergestad. Thank you for joining us. Dr. Kevin Masur is a surgeon with Arizona Advanced Surgery, part of a multi-specialty team providing advanced, minimally invasive procedures across Phoenix. Welcome to the show, Dr. Masur.
Thank you. Thank you for having me.
All right. So why don't you give everybody sort of a quick snapshot of your group and where you service throughout the Valley and what you specialize in?
Of course, we are a multi-specialty group that generally falls within the scope of general surgery, although we also do have wound care services. And so we have colorectal, we have breast, we have plastics, we have general surgery, we have minimally invasive surgery. We also employ trauma surgeons and acute care surgeons. I'm probably missing at least one or two. We have about 18 locations scattered across the Valley. We have a pretty heavy concentration in the West and Northwest Valley, a little bit in Central Phoenix, and then a lot in the East Valley and South Scottsdale areas. We have providers scattered across those various office locations and have providers that go to almost every hospital in the Valley.
Okay, nice. Very, very broad. That's a lot of relationships you guys have grown over the years. And how long has the group been together? I mean, I know it's changed and morphed in different groups.
Yeah, the current group was a merger that occurred in early 2021. So right in the middle of COVID, we went through a merger. So that was a unique. We'd been building for it for years, so we just kept rolling along in that sense.
Sure.
But I can speak about our side. So we came from the East Valley, and that group started in 1998 with three doctors that founded that group, one of which who's still in the group. And then it's just grown exponentially since then. When we got to about 15 or 16 surgeon partners on the east side, we joined a group of 17 surgeons on the west side of town to form the group.
Okay, excellent. Now, what's been the biggest challenge, just speaking on terms of the greater group right now, and growing through COVID and in this current climate of reimbursement issue, everything? Can you speak to some of the challenges you guys have had to or are enduring?
Sure. I think there's a lot of changes that have occurred even just since our merger, 5 years ago. One, there's been a complete flip in the state of Arizona from where the vast majority of providers were in private practice to now way more than 50% are employed by health systems. We remain in private practice, and so that's a constant challenge for us to maintain our private practice status, but also to recruit in an environment now where the majority of people coming out of practice or coming into the Valley are getting employed by health systems. So it's a big difference for us with who we compete with to employ or to hire, good union surgeons.
Why that shift? Why has that happened here? And what are the pros and cons of it?
Yeah, so the shift has been slower here than it has been in a good portion of the United States.
California, for example?
And Florida and New York and Ohio. There's a lot of big, heavily populated states where the flip occurred maybe more than 10 years ago. And part of that is just how reimbursement works. A lot of people don't realize that the majority of healthcare dollars, whether it's private insurance or government-funded agencies like Medicare and Medicaid, the majority of that money goes to hospitals and hospital systems. And then the next largest bucket that those payments go to is for durable medical equipment. And so physician reimbursement is anywhere from about 3 to 5% of all healthcare dollars spent. And so since the hospitals have commanded, larger and larger pieces of that bucket, they've had a bigger pool to draw from to be more competitive with hiring. I think the other part that has shifted is the people coming out of medical school and residencies, where there's been a bigger flip from, I think, people who go into medicine and think of it as a career, something that they're going to do the rest of their lives. They're going to, they're going to work, incredibly hard and take care of patients and make a lot of sacrifices to it's getting to be a different mindset in the younger generations where I think many are starting to think of it more as a job. And then as a job, you want some of those securities of steady salaries, caps on how many patients that are seen, guaranteed vacation, that kind of stuff.
Right.
A big example of that is my wife is actually a surgeon in our group as well.
Okay.
And we just had a baby 7.5 weeks
congrats.
ago. Thank you. And, people always asked us as we were approaching, our daughter's delivery date is, wow, so how much time does she get, for maternity leave? And we said, well, actually, we're in private practice and we're owners of our company. And so
it's a need what you kill scenario.
Correct. So maternity leave means you had to, do something to prepare yourself to be able to take that time off.
Yeah.
Whereas you flip that and you work for a large health entity, that's just part of your benefits, right? You have that benefit of being able to get your full salary while you're on maternity leave because it's a guaranteed benefit of sorts.
Right.
So I think there's just a lot more desire and push for the younger generation to have those guarantees and things built in. But I think the one of the cons that we've seen, and it's been in a lot of our, kind of free journals that come to our free, surgery news and things that come to your house, whether you subscribe or not, but you do kind of read some of the editorials, and it's been spoken about a lot at our national surgical conferences, is the impact of that shift and how it lends itself to folks that don't end up staying around very long in one location.
Okay.
When, for instance, if you joined a group and you wanted to build up those referrals, right, and you wanted to build up in that environment of work, you had to do that over time. But then when you invested all that time, energy into it, you wanted to reap those benefits for the rest of your career and continue to do that. Whereas if you go and get employed, let's say by a health system, their built-in referrals already coming in your door. And whether you garnered those or not didn't really make a difference. And then if you leave, someone else just slides in and picks up that work. And so what you see is people that work 3 years, 5 years, 7 years in different places, and then they move on to another place. So you see this workforce that migrates around, as opposed to what used to be, I think, doctors, when they settled in a community, they entrenched themselves in that community. They became part of that community. And I think you're seeing that less and less. So for me, that's one of the big cons that I've seen with this shift, is that you just, you start to, maybe, like for us, we find a good primary care that we really like. And we get a good relationship, and they know they can call us if they need us, and they send their patients. But then something changes in their management structure, and maybe they don't like something, they move to a different entity, and now they're gone. Whereas before, if that primary care came and took out a big bank loan and hung a shingle on the street corner and said, I'm going to be, Joe Smith primary care, they put so much energy and effort into it that they engross themselves in that community, and they're not going anywhere. They're going to stay there, pretty much reliably for the rest of their career.
Right. They're all in. They're not just in their service because they want you to come back, right? But also in their relationships, not just with other doctors and affiliates, but with the patients, right? It's historically an industry where it's very personal, and it's another downside I see that you touched on there as well, which is, if you're plug and play, you're just a cog in a machine. People don't invest into relationships with the patients very well, and you're not worried about, if you do a bad job, I'll just go somewhere else type of thing. That level of accountability seems to be impacted.
For sure. Nope. I think there's some people that have, commented that it's a similar shift to how residents are educated. We used to have no work hour limits. We had no really rules governing it. And I would never say that is the right way to do it. That also had its own downsides of, people that got burned out and all this other stuff. But, when you're on call and it's the 22nd hour of your call and one of your patients gets sick, you wanted to stay and make sure you were there to provide that service. And with one of the unintended consequences of work hour limits and things that you would think would maybe help, the like the physical a bit, the physical toll that it takes on trainees, is that it's also shifted that feeling of, well, my shift's up, so I'm done. Now that patient
Right.
is this person's. So if you start to train an entire generation of people to feel that work is in shifts, then
Right.
it takes away some of the personal connection you have with the patient. You're like, nope, I'm just on this shift, and when I
Sure.
leave, I'm off shift.
And the
And
professional responsibility associated with caring for that patient.
correct. Yep. No, for sure.
Huge.
And again, these are not universalities. There are definitely people that work for health systems that take amazing care of patients, and they absolutely are invested. It's just the mindset is starting to shift,
Mhm.
and I think there are some challenges that the healthcare industry is facing, and leadership in these healthcare industries are facing, is trying to figure out ways to um, capture the mindset and drive and maybe personal sacrifice that has been a part of physicians for decades,
Right.
but translate that to a different work environment, which is hard.
Sure, sure. And I guess some of it I've seen from both sides. I guess I've seen when you're not as invested, right? You didn't sacrifice as much in the training and other stuff to be there, and I think the lack of respect on the other side from patients also impacts that buy-in, right, from both sides.
Oh, absolutely. We actually, I know so many patients do this, and it's gotten to the point now where it feels very normal, although it shouldn't, is when they come in and they're like, well, Google told me,
Sure.
dot, dot, dot,
Yeah.
but it even
WebMD says
happens.
this.
I know, but it even has the flip side of, well, I read on social media, or I read this or read that, or
Mhm.
I saw a video about this. And what's tough is trying to navigate through that sometimes with patients, is to say,
Sure.
like, I understand that when you put in this data point, that data point, or you Googled these words, but maybe that didn't apply to you, right? I mean, I think that's why you needed physicians, is to take and treat you very specifically. However, again, if you look at healthcare over the last 15, 20 years, the trend has been towards algorithmic care and making it less individualized. And that and sadly, there's been various papers published that show that algorithmic care in some ways is better than individualized care. And so it does make it hard for people to maintain their faith in physicians when it feels like, again, you've got a growing population of people who think of it as their shift. And
Mhm.
then they're applying an algorithm to you, which the computer can apply that same algorithm to you, and it's going to be
Mhm.
right enough to be okay. But again, I think there's still enough people in healthcare that feel like that's not okay. That we really should be trying to individualize that care, apply that knowledge to those individual patients. But I think it's becoming less and less as time goes on.
Sure. Everybody's different. I mean, as a surgeon, you cut into somebody sometimes like, well, that's not normal.
Of course.
I,
No.
right. I have to adjust everything I'm doing now because as we got into the tissue, we found out this is, yeah, you have to
Oh no.
see all the different cases. And
We have surprises every day. I had a patient relatively recently, without trying to violate HIPAA or anything, but we anticipated doing surgery A because we expected to find A in surgery, and
yep.
not only did they have A, they had B, C, and D, and
Right.
they were all related, and they all had to be addressed because you couldn't get to A until you addressed B, C, and D. But
Right.
what was a planned 90-minute surgery became a 4.5-hour surgery.
Right.
And the patient's doing great and recovering, but it really does hammer home that point that we did not come off of an assembly line. We were not all built to specs. We don't
Right.
respond the same to everything that we do. We don't even respond the same way to medications. One person
Exactly.
takes one pill for blood pressure, it does nothing for the next person, and vice versa. So it does make healthcare challenging in that respect. But again, I think for the surgeon scientists out in the world, or the physician scientists out in the world, that kind of click with your brain, your scientific brain. It's that curiosity that keeps you going and keeps you sharp in taking care of patients.
Right. So that's a great misconception, maybe, and challenge in the industry for sure. Is there a lot of competition sort of within the surgery centers for caseload and working with different facilities and primary cares and getting referrals and all that?
There is, and I've found this irony that I've not been able to like rectify in my brain. Is we keep reading about how there's not enough surgeons for the patient population, right? There's, it used to be, I think, that there was about one surgeon for every 50,000 lives, and that was enough to kind of keep one surgeon busy. And now one surgeon is having to cover almost 120,000 lives because their population grows, but the number of surgeons hasn't changed, or the number of people who are actively still performing surgery. People aren't working until they're 75 anymore. There's people retiring at 45 and 50, right. And again, for their own reasons. And so that we're always hearing about surgeon shortages. So that would imply in my mind that there are an excess of patients.
Right.
And we should all be
5-6 months to get in with any surgeon. Right.
Correct. And yet there is actually pretty intense competition at times for people to try to, turn the course of maybe a primary care office, say, no, don't send them to them, send to us. Don't go over there, come over here. And there's, sometimes intense competition for call spots on a call roster to take that call at the hospital, which is, pretty much instant guaranteed work, right? You didn't have to do anything. You had to show up that day, and
somebody comes in with appendicitis and
correct.
You're
and
the guy.
So you would think there should be less competition, and yet there's still quite a bit. So I don't really know. I have not been able to understand that irony, other than the way we are reimbursed is still fee for service. So if you do A, you get paid B. If you do C, you get paid D. And so, and over the last 25 years, average reimbursement has steadily gone down. So what you used to be able to do, maybe 6 or 8 cases a week 20 years ago, to hit that same number, you got to do 12 to 15 cases a week. And so you're constantly out there trying to track down a few more patients, get a few more people to come see you, try to work on that so that you can keep, at your level of reimbursement that you have kind of grown accustomed to.
Sure. And your practice, it is Arizona advanced surgery, right? It's you guys do minimally invasive. You're always, cutting edge, keeping in a competitive sense, I guess. You guys provide top-notch care and services. And I imagine, do people really track outcomes and show that to other people to try to make sure you can show how good your practice is compared to other practices?
So I think that has continued to evolve, but the answer is yes. Are we really good at tracking it? Probably not. But I think they do continue to track certain things. So for one, now many private health insurances have tiers. And so do most of the Medicaid programs here in the state. They have different tiers of providers. And so what they have looked at is what they feel are good measures of quality work. Now, again, we can argue what those measurements are, but they are what they are currently. So they look at things like, re-presentation to the emergency rooms after surgery, or readmissions after surgery, or unexpected return to surgeries and things like that. And so they're able to put providers in tiers. So then if you would say, let's say you're having knee pain, and you want to look up an orthopedic surgeon, in the past, you'd go to your primary care, say, I'm having knee pain. They do x-rays and say, yeah, your knee looks kind of, I'm going to send you over to my buddy. He's a great orthopedic surgeon. You go, okay. And you'd go wherever your primary care told you. Now we get a lot of patients that will tell their primary care, I already looked it up on the website. I need to go see a tier 1 person. Here's the list of people. Do you know any of them? And they'll go, oh, I've heard of that third one. And that's where they'll go, kind of thing. So I think the insurances are trying to get their patients to in-network high quality providers as best they can. So that's one aspect of it. Number two, the hospitals have quality programs. And if you don't meet their quality marks, that might get you kicked off a call roster, because they can't have lower quality people taking call, because that would reflect poorly on the hospital. So
Sure.
for them, they have different metrics and benchmarks that they use. And again, as a larger group, we work with those hospitals to not only develop what those metrics are, but also to follow them, maintain them. And again, if we have a provider, in our group that is on the low end of that, then we have to work hard to bring them up, to get them in that category. So insurances have it, health systems do have it. In our own group, we actually have a quality program that we use that tries to track those things. And again, it helps us to identify maybe providers that are on the lower end of different things. And so we do try to, we're still developing ours. It's not perfect yet, but we work with that to try to make sure that if we have anybody that's, again, kind of on the low end, we can help, bring up that floor for the whole group. And then lastly, the government, tries to do this as well. Although on an individual provider basis, I don't think they have figured out an awesome way to do that accurately. But you do see, and we get feedback from different government agencies, CMS, Medicare, stuff like that, where we have to show that we have good outcomes, and then that affects our reimbursement.
Right.
And then
Okay.
that information is, oftentimes it's public.
Okay. So there are systems in place at different levels trying to
For
accommodate
sure.
for
I
that.
think at the same time, though, many people end up going to Google Health Grades, social media, and they look at star ratings, and
Right.
they're just thinking, all that other stuff sounds great, but it says he's 4.9 stars. That's where I'm going. And so I think, one of the challenges of a large group and any people in healthcare now is to, have a marketing team and, an online presence team and folks
Sure.
to help make sure that you maintain, decent online, stats, or
Right.
address issues with patients that are having concerns about, the care you've delivered. Many times as you work through those, they're not anything that was done wrong. Their communication breakdowns, there maybe didn't return a phone call fast enough, something that honestly is, pretty easy to fix and rectify. But it still affects your star ratings.
Right. Okay. Thank you for that. Now, I'm keenly aware, but I don't think most people necessarily realize the personal and financial sacrifices that it takes
Mhm.
to become a doctor, and not just the years of training, right? But the low income, the debt, all that stuff. And
Sure.
with the economic landscape changing, reimbursements, all that stuff, what do you think young doctors should be concerned about or be thinking about in that trade-off of time and sacrifice for where you are going to be in the next 5-10 years?
Sure. Well, I think one of them we're already starting to see, which is people are choosing to go to PA school or
Mhm.
becoming advanced nurse practitioners, as opposed to going and incurring the extra time and debt to become a physician, when they can actually get a competitive salary with a decent quality of life in the healthcare field. So you're already starting to see a shift in people that are choosing to do things other than becoming a physician. And so there's a lot that take that path for sure. I think the other thing that it affects is, what specialty you go in. So, you go to medical school, maybe you have an idea what you want to do, maybe you have no clue. But when you're getting to the end of medical school, and now you're sitting there with $250,000 in debt, $300,000 in debt, and then you go out
Mhm.
and you start looking and you say, okay, what do I want to be when I grow up? And you think, oh, I want to be a family doctor. I love the continuity of care. I love working with families. I love, being
Right.
there in that, thing. And then you go, but wait, they only make, 185.
Right.
I don't, I don't think I can do that. You
I
know,
don't know how that would pay off my debt within 30 years.
Correct. Whereas again, this kind of goes back to the earlier part. They might get an offer from a health system for 225, and they go,
Right.
well, no, hey, there you go. Like that is more interesting to me. But I think what you're seeing is, people are trying to do more things to not do the lower paying aspects, which is really sad because we need more pediatricians, OBs, family doctors, et cetera. But they're all choosing to go to the higher paying specialties because they want to try to erase that debt sooner rather than later. Or they're doing additional training on top of the basic training. So again, you used to, you looked at it, and people going into general surgery, for instance, it's 5 years of post med school training, and 80 to 90% went off and out into the workforce and became general surgeons. Now it's about 20. The other 80 are all going to do fellowships. So they're going to go now do a fellowship in minimally invasive surgery, robotic surgery, plastic surgery, cardiac surgery, whatever it is, because generally those will all pay even more than a general surgeon. So then they're all kind of aiming for something. And that's also a function of, again, with different aspects of training, maybe not feeling as ready to go out and be a general surgeon. But then they go do that fellowship, and now they feel more capable to do it.
Right. Okay. And there's generational differences in terms of patients, as well as like you said, they've changed the hours and the training and the demands on them, and every generation seems to think the new generation is soft or so forth.
Yeah, I know.
Yeah, but burnout's a real thing, and there's a lot of the stress. It's not the same profession it was, 50, 20 years ago. And what are your thoughts on that in terms of like the workload, independent of the financial stresses, right? Just how it's changed in general.
Again, I think it's going to have some ramifications as time goes on, and I don't have a magic wand to fix it for sure. I wish I did, and I don't even know what the fix would look like. But you definitely see that if you, again, in private practice, if you wanted to see 20, 25 people a day as a surgeon or 50 patients a day as a primary care, that's what you did, because that's what you did to make sure you were seeing as many people as you could and taking care of folks. And if you're maybe, again, thinking of this more as a job than a career, you're like, oh no, I'm capped at, this number of people per day. And so that just exacerbates the shortage, right? Because now you have those less spots. And again, I was reading a great article, maybe 6 months ago that was talking about the rise of urgent cares, because now you can't get into your primary care the same day quite often, right? And so even if it's something simple, you were playing basketball, at the park last night, and you think you sprained your ankle, and you woke up this morning, it's super swollen. Again, in the past, you call your primary care, you come in, they go, yeah, it looks like a sprained ankle, we'll get some x-rays, blah, blah, blah. Now you call the primary care, they're like, oh, they can see you next Tuesday. And you go, oh, then I'll go to urgent care. And so you've seen this explosion in urgent cares, not just volume, but their capacities and their capabilities. And you've seen an explosion in freestanding emergency rooms. So they're not attached to any hospital, but because they can capture thousands and thousands of patients who really just needed a primary care, but they couldn't get in. So you're seeing things shift in that regard. But I think a lot of it does come down to, again, just changes in I want to say work ethic, but I don't want to make it sound like people are lazy now, because that's not what it is. It's just it's a change in the perception of,
I thought you said job versus career is a good one, right?
Correct.
Yeah,
it's when it's a career, it's a passion. It's becomes part of your life. Maybe some people took it too far and it overtook their life. But when it's a job, it's what you do between this hour and this hour. And then when I'm not at my job, I don't want to deal with my job. In private practice, I might work all day, and then I still come home and I still have to finish my charts from office, from the night before. And then just in general, private practice docs tend to be more engaged and more involved in medical staff responsibilities. So maybe I'm the chairman of peer review at one of the hospitals. I might have to sit down and review, 15 cases that came through the peer review system. And then I might go do this project or go do that project. And that's all stuff that, a lot of it is uncompensated. It's just part of being part of the community and part of the medical staffs and part of the health systems. And that's a difference in my mentality. Again, maybe compared to someone who goes, nope, when I was done at 5, I'm done. I don't do anything else past that. And I'll resume tomorrow morning at 7. And someone else is on call tonight. And if anything happens, it's not me.
Right. Which is not, some professions can do that. And I guess some surgeons do that, but most
Sure.
of the surgeons I know, even if I'm not on call, it was still my patient. And if they have a problem, they still call you,
Correct.
right? Is that
Or
still
if
kind of the trend?
it is, and even though again we're in a big group, so you can't be on call for yourself 24/7, you'd never get a day off. But if you're in town and one of your patients comes in, we always, our group is very big on those personal connections. And so if my partner's on call and my patient, shows up and it happens to be at, they may not call me at 2 in the morning, but they're going to call me at 7 p.m. and say, hey, you know, John Smith, I'm just making up the name, right?
Yeah.
Came back in, looks like you did surgery on him last week. Seems like he's having some trouble. How would you like me to handle this? And the vast majority of us are like, I'll come take a look. Let me come take a look. It's my patient.
Right.
Whereas,
Which is awesome.
thank you.
Thank you.
But we hear stories quite frequently of people who say, I met my surgeon in pre-op and I've never seen them since.
Right.
They've had 3 days in the hospital recovering, 6 outpatient visits, and they don't have a clue who that surgeon was because they met them in pre-op and they
Right.
move on. And I don't think we could, at least the people in our group that we associate the most with and the ones that kind of work together in our little kind of pods in our group, I just can't see anybody doing that. It's just not,
Okay.
it's not in our DNA to do that.
Right. The values associated with your group attract certain people which fit, and that's a testament to all of you. That's great. As we wrap stuff up here a little bit, I want to ask you a little bit about like future plans, legacy plans. And often I talk about impact. I mean, you're already having a crazy amount of impact as a physician, right? With all your patients and stuff and the community. Maybe more personally, right? Because I think if it's okay, you just had a child, right? I don't know if that's your first, but
it's my first.
Nice. Yep. Congratulations.
Thank you. Yeah. Nope. We have a lot of things that are going on in our lives. My wife and I, we've been married now we're just coming past 3.5 years. And that's our first kid. There might be more, there might not. We haven't quite figured that out yet. We're still navigating our way through taking care of a newborn.
Sure. It's a lot. It's a lot.
Yeah. And, but personally, my wife and I, we do surgical mission trips down in Honduras. And so we continue to expand that program and get other surgeons to come down with us. And we do surgery for a week at a time, usually doing about 40 surgeries in 4 days. And we take care of a very, very poor, very indigent population in kind of the north central part of Honduras. And so for us, that's a big part of our lives going forward. Our group continues to expand. We're constantly, we work with residents and we meet different people through different circles. And so we are constantly trying to grow and expand. And so, we have one surgeon that just started with us last fall. We had another one that we were hoping would start with us this next fall, but she ended up taking a job in another state. But we, as a group, our goals are to continue to expand reasonably. If you overexpand too quickly, you probably exhaust your resources too quickly. But continue to expand. We also are working with even other small groups to continue to build a group that we can continue to be proud of and be a competitive entity in the market and continue to provide great care. The challenges sometimes of bringing folks on is to still maintain that same feel and quality they get no matter which office they go to, in our practice. That's one of our internal culture goals. But we continue to work on that and not just limiting ourselves to the Valley. We've started to reach out and communicate with people across the state, trying to see if there's relationships we can build and things that we can form to put ourselves in a more competitive spot as time goes on. We never know how healthcare is going to change. I feel like it ebbs and flows every 5 to 10 years. Things change and we have to adapt and respond to them. And so that's always a constant focus for us, is how do we continue to navigate through that part. And all those things are constantly in our minds as we move forward.
All right. That's good stuff. Yeah. You got your private practice sort of legacy, right? You have the charitable stuff. Having kids makes you think about legacy too.
Of course.
Well,
no,
exciting,
for sure.
exciting times. That's excellent. All right. Well, Dr. Masur, if people would like to connect with you or learn more, where can they go? What should they do?
Yeah, so for the most part, it's easiest to go to our website, which is www.arizonaadvancedsurgery.com. I'm personally at our 3501 North Scottsdale Road location, which is a stone's throw away from Honor Health Osborne Medical Center. But our group, again, spans across the whole valley. And so even if you can't necessarily come find me, again, we've got great surgeons all across the valley. And you can generally find someone who's relatively close to you that can help provide you with care. We actually see patients from all over the state. I get referrals from all over the place. And again, we're always happy to see folks whenever we can. But yeah, usually the website's the easiest.
Okay. Excellent. Well, thank you. Thank you, everyone, for listening and watching. Thank you very much, Dr. Kevin Masur, for sharing your insights into the industry today. This is great stuff, and you're doing great work. Thank you.
Sounds good. Thanks for having me.
Inspired by our guests? Visit PhoenixProsperityPodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.